Good evening, aspirants and our honorable faculty. Let's commence our today's class of EDIC Part 2. Today's domain is about respiratory, which would be conducted by Dr. Deepak Gupta. He is a consultant in critical care medicine at KAILASH Deepak Hospital in Delhi. His area of interest are as follows, like critical care, field of sepsis, management, and management of difficult airway. So over to you, sir.
Because it will be a long class, this time we are covering the CCS about respiratory medicine. We'll be covering one case. And the second part would be regarding the CBS, the table viva. What are the things which are asked in the table viva? Few of the points we will cover, few of the cases. Welcome everybody to this new batch. We are starting this batch. This is the first one. As you all know, in the introductory class, all of you have already been apprised regarding what is the pattern of EDIC 2 exam, how to go through it, the books which you have to read. One by one in every week, we'll be taking one systems. So one or two things again I want to emphasize is it is not that when a case comes, it will be limited to one system. The case can jump. There are 4 to 5 vignettes. In each vignette, the case runs from one system to other system. Okay. EDIC 1 is totally theoretical class exam, so you have to read only, right? But this EDIC 2 is a viva. So you have to speak. Till you start speaking, you will not able to pass, even if you know the answers. So we will keep this class completely as an interactive class. I'll be giving the questions. Whatever you think the answers are, you just respond. Then we'll see what the correct answers and how to proceed in the case. Then only it will be helpful to you. Just if I will be dictating the question, then answer question, and that would not help you in EDIC 2 exam, because you have to start speaking itself. Okay. So whenever the question is there, whoever want to answer can unmute and answer. We'll see if even if the answer is wrong, that's not a problem. This is not the actual exam. So we'll correct, and next time you can get it correctly. Okay. So let's start with the case. As the EDIC 2 format is, this is the way the case comes to you. So this is vignette 1. In this, the presentation of the case is there. This is a 42-year-old female with no comorbidities, presented with ED with fever, myalgia, malaise, cough with expectoration, and acute onset of breathlessness for 4 days. On examination, she was found to be febrile, restless, respiratory rate of 42 per minute, pulse rate of 131 per minute, BP of 150 by 80, respiratory rate 35, oxygen saturation of 79% on room air. On systemic examination, crepitations and bronchial breath sounds in the right lower zone. On chest X-ray, shows non-homogeneous opacity in the right lower lobe with air bronchogram. There is no past history of admission to the hospital. Patient is known case of diabetic, is on OHAs and is well controlled. Okay, so this is what the ABG we got. The pH is 7.34, the PCO2 is 48, PO2 is 51, bicarb is 23, base excess 2, with anion gap of 7.6, and lactates are okay, that is 1.1. So this is the X-ray which was done for the patient. Already the X-ray has been described in the thing only in the case itself. Right lower zone haziness is there for the patient, and cough with expectoration. So my first question would be, what are the differential diagnosis in this patient? What do you think? You have to enumerate what are the differential diagnosis. Anyone?
Community acquired pneumonia.
Very nice. You have to tell the DDs. It's not a specific, it will be that only. More whatever things you can think, seeing this X-ray and the clinical picture.
Community acquired pneumonia with the pulmonary thromboembolism.
Yes, can be wedge-shaped opacity occurs in that also. Tachycardia is there, hypoxia is there. Any more things? Right lower zone patch.
Aspiration pneumonia?
Yeah, can be there. More things, see, this exam is totally about speaking. Whatever DDs you see, whatever you can think regarding any patch in the X-ray, you start speaking. You don't know whatever things are the answers are written in examiners. The one examiner will be just seeing on the iPad and marking whatever you say. If this matches, how that much marks you will get. Any more DDs can you think about? So this can be acute bronchitis itself. It can be exacerbation of COPD, aspiration pneumonia, someone said very correctly, acute exacerbation of asthma, pulmonary embolism. Yes, you told it. It can be a bronchogenic carcinoma also, regarding like a thick patch is there in the lower zone. It can be some mass and pneumonia, that is a community acquired pneumonia. It can be there. So these are the DDs. The more you try to speak, some of the answers will come correct. Okay.
Sir, I have a question.
Yeah.
Like you're saying that, I mean, it might be COPD or asthma. So without giving a hint about comorbid conditions, so can we say this?
Yeah,
COPD or asthma?
it can be recently diagnosed. The patient may not be having. Such picture of a X-ray can come in this all the cases.
Okay.
Sir,
So,
one more thing, sir.
Yeah.
I just wanted. Sir, this in this case, no, it is very clear that it is most likely a community-acquired pneumonia. Then where is the question that we go for other diagnosis? Maybe, see, it could be exacerbation of COPD, asthma, pulmonary embolism. But the presentation itself, shortness of breath for 4 days, and you are having a definite shadow on the chest X-ray with a falling saturation.
Yeah.
And patients' other vitals, lactates are everything normal, like what you have told in this thing. It doesn't look like he's not in septic shock or anything, or whatever shock or anything. So why to give so many DDs when you are very clear?
No. You are very clear. Are you 100% sure it is it's pneumonia only?
No, but if we keep doing all these differential diagnosis, there will be n number of DDs, no, sir. Like pneumonia should be the primary diagnosis, first one.
Yeah. See, one thing I am telling you, these are all the DDs. These are not in the sequence of importance. Means it is not that your first DD is acute bronchitis. Every DD has got equal marks. Are you understanding? If the 4 marks are there, if you tell pneumonia first or you tell pneumonia last, you will get 1 mark only for that. See what changes have occurred. I am trying to tell you. Previously, before 2017 and all, 17, 18 something, there were some things called as 5-pointer, 3-pointer, and then 2-pointer. So in this case, clear cut, anyone can say it is a pneumonia. It is a community acquired pneumonia, cough with expectoration. It is very clear. For me also, it is very clear. First diagnosis will be that. So previous the marking system was ki if you tell the pneumonia, that will be a 5-pointer question. You will get 5 marks for that. Then the other DDs had got separate marks. But now the system is all the DDs have got equal marks. Whether you tell it first, you tell it, don't tell it, even if pneumonia you don't tell it. Then also how much marks will be there if 4 marks are there for this question. So whatever DD comes to you, because see, you cannot 100% be sure it is pneumonia. Tachycardia is there, hypoxia is there, can be an embolism. It can be just on X-ray, you cannot define it's a pneumonia. It can be a mass hidden in it. It can be a bronchogenic carcinoma, which may have now presented with cough infection and this right lower zone. It can be an aspiration pneumonia. So you have to try to keep as much DDs as possible. You never know what the answers the examiner is having. Are you understanding what I am trying to emphasize?
Sir. Yes, sir.
This is the type of exam. This only things you have to learn.
Yes.
Seeing the DD, seeing the X-ray, anyone will say to pneumonia and nothing else can be. But you are not 100% sure. No, we'll see the case further how it goes.
Okay, sir. Thank you.
Okay, so you should try to say as many DDs as possible.
Okay, sir.
Now, what is your provisional diagnosis? Now, this is a very specific question. Provisional diagnosis would be, it would be single.
Pneumonia.
Differential diagnosis can be many. So what is the provisional diagnosis? This is
community acute pneumonia.
Yes, this is community acquired. Here you can specify when the DDs are asked, you have to say multiple differential diagnosis for that. because you're not evaluated him completely, the patient. You don't know exactly what it is.
Type 1 respiratory failure is not a diagnosis.
Sorry, I couldn't listen to you.
Type 1 respiratory failure, we cannot tell. Pneumonia with respiratory failure.
Which failure? Sorry.
Respiratory failure, type 1.
Yeah, respiratory failure is there. That is but the provisional diagnosis is community acquired pneumonia. This is a respiratory failure, surely. This is a respiratory failure.
We should not tell with respiratory failure. Pneumonia with respiratory.
Respiratory failure is not a differential diagnosis. है ना, respiratory failure तो है, it is there, respiratory, but the cause, what is the cause of it, that you have to tell in the DDs, na? You cannot say in the differential diagnosis that is a respiratory failure. Respiratory failure is there because cough with expectoration, desaturation, X-ray suggestive, and ABG is suggestive. So this is a respiratory failure. But differential diagnosis, you have to keep what are the differentials diagnosis in that, and what is your provisional diagnosis. Okay. Clear? Should we move forward?
Yes.
So respiratory failure is there, but the cause, the differential diagnosis, you have to keep it. And that you have to tell. So now the next question is, how will you start the initial resuscitation for this patient?
Okay, first check the airway, sir, if it is patent or not. If patient is conscious and oriented, any drowsiness, we should check. Breathing because of decreased saturation, keep oxygen support. Whether it is, if there is normal respiratory rate, keep a normal oxygen mask. If there is patient is tachypneic, we can go for NIV support or HFNC support. Hemodynamical stability with
See, the initial resuscitation part, always you should remember, always speak ABC first. For any resuscitation, if question comes, always you should speak of ABC. Initial resuscitation, airway, look, listen, feel, snarling, gurgling, any stridor is there, breathing, signs of respiratory distress, breathlessness, tachypnea, everything is there. And circulation, you have to see the pulse, rhythm, temperature, capillary refill, whether the patient is in a shock or not. Okay, this will be the initial one. Then what are the positive organisms are most likely in this patient? Can you enumerate what are the causative organisms for this? Now, the provisional diagnosis is already community acquired pneumonia.
Yes.
Maybe Streptococcus pneumoniae.
Yes, very good.
Haemophilus influenza.
Speak fast.
Haemophilus influenza.
Yes.
See,
try,
one
suggestion. Try to divide the causes and organism such questions into bacterial, viral, then most of the things are covered. Yeah, please say.
Sir, bacterial, it can be Streptococcus pneumonia, Haemophilus influenza. Because the patient is a diabetic, it can be Klebsiella or Pseudomonas also can occur in this patient.
Very nice. Any more? Viral?
Viral COVID-19 can cause influenza.
Rhinovirus.
So Streptococcus pneumoniae, influenza, atypical organisms also can cause such pneumonia, Mycoplasma, Legionella, viral pneumonia, influenza, para-influenza. So divide it into various parts, you will get the answer. Okay, because there are separate marks for separate answers also.
Sir,
so all the things can be there. They can present as atypical pneumonia, viral pneumonia, bacterial pneumonia.
Sir, I mean, should we mention COVID also? Because the X-ray doesn't...
Yeah, you can mention. Definitely. I have not put in the answer. You can mention. It is not that COVID pneumonia, it would be complete, exact the presentation. It can be.
Okay. Bacterial, we can also include Klebsiella.
You can see, I'm telling you, whatever answers I'm telling for this, these are the most appropriate, which I feel. This is the catch in this EDIC too. There is not 100% specific answer for each and every question. This answer would be this only. Whatever the best possible answer in this situation, like in many further also we'll see what would be the management, what would be the antibiotic. I would say this should be the antibiotic given to the patient. Some would say no, this antibiotic, no, I would change to this antibiotics. It is up to what examiner wants from you. how much it is correct, best possible from their point of view. So that is why it is not always clear Kini, the answer of this question is this only. In EDIC 1, if an MCQ is there, the answer is 100%. If D is the answer, D is the answer. Here, this is totally clinical knowledge. Okay. So you can include, I would say COVID, definitely you can include in this, can present like this, you can present as Klebsiella. That also DDs you can get. The most appropriate I'm telling. Now, what are the risk factors for community-acquired pneumonia?
Elderly.
This is a general question. What are the risk factors?
Elderly patient, diabetic patient, known case of asthma or COPD patient.
There are a list of risk factors which can cause community-acquired pneumonia. You can see lifestyle, environmental, comorbidities, medications, immunocompromised patients. So this is a general question which I had put. There are many number of risk factors which can cause community-acquired pneumonia. So next question is
in like this question, isn't like that question we should answer the whole list.
No,
divide it.
you can enumerate few of them which specifically you think. There is a very big list. This is a general question actually. So you can specify the most common factors which causes the community acquired pneumonia and divide it into parts such as immunocompetent patient and immunocompromised patient, which can be the causes. See, in the exam you will have two types of questions. One questions will be specifically about this case itself, and few questions will be the general questions. Just risk factors. They're not asking only in this what are the risk factors. In general, what are the risk factors for community acquired pneumonia? Now the next question is, how would you risk stratify this patient? In this patient, community acquired pneumonia, how you will do the risk stratification?
Curve 65.
By curve 65, right?
Very nice, very nice. Absolutely correct. So it is a curve 65 scoring system which can be used. It includes 5 factors which are confusion with an abbreviated mental test score of less than 8, urea more than 7 millimoles per liter, respiratory rate more than 30 breaths per minute, blood pressure systolic less than 90 or diastolic less than 60, age more than 65. Now you have to see how much are the total points out of this, and the inference will be drawn from that. If only 0 to 1 points are there, then treatment in the community. If 2 to 3 points requires hospital admission, and if 4 to 5 points requires critical care admission. Okay.
Sir, I have a question.
Yeah.
I mean, when they ask this kind of question, so how do we calculate? Should we calculate before all hand or?
No, curve 65 scoring would be on admission only. When you see the patient, then only you classify. Confusion is there, yes or no? Once you get, as soon as you get the report, what is the urea, what is the respiratory rate, what is the blood?
I mean, when the examiner asks us the question, so will they give us a time and we again need to look at the history and calculate the curve 65, or that's my question.
When such question comes, you should remember what things are there. See, this first vignette will be given to you previously only.
Okay.
So you are almost 10 minutes, 15 minutes, so that you can note down the points, what are things you have got in that.
Okay. And when they're asking this sub question, sir, I mean, do we again have an access to that vignette?
No, I don't think so. No, they don't go back to there itself. They will ask you.
Or is it possible that we can make a summary of it? I mean,
yes, that only the previous first vignette is given. I told you in the introductory class also, na? You try to memorize the things, how much are there. You note down the important points, whatever the abnormal findings are there, and try to expect questions, what questions can be asked. Now, this case was clearly a pneumonia case. So you should expect these questions will come. Summarize the case, risk factors, risk stratifications, management. So antibiotic, what you have to give. So you have to expect these questions, and that you have to tell.
Okay. So because in EDIC 1, pen and paper is not allowed. So in EDIC 2, so
no,
where do you...
in this, you can keep a paper and note down the things previously.
Okay.
It will allow you.
Okay.
Okay. Because this vignette is given previously, you will get even time. 10 to 15 minutes previously, 10 minutes to 15 minutes, you will get that you can read the case and make a picture, and just you can note down the important points from that. Further vignettes you don't get the time, but the first vignette you will get some time.
Okay.
Okay.
Thank you. Yes.